Okay, let's go ahead and get started here. Our first speaker in the lightning round industry innovation session is our very own John LaRochelle from Sodexo.
Yep. All right, so welcome again. You get me 2 times in a row here, so appreciate your time. Really, what we're looking to do is, I don't want to spend a lot of time up here because I think the important thing is the collaboration of this group. The power of what we're going to do over the next 2 days and beyond is really the afternoon sessions. What are the actions that we're going to take as a team, and who else can we bring into this process to further, get to this solution? So with that, I'll go over a couple slides and give you a couple things. But Sodexo really has been moving towards, it's been a journey that I've been on and a passion of mine for probably 10 years now. And I've really been fighting a profitable organization. I mean, we're not a nonprofit. We're a profit-bearing, publicly traded company. So we're looking to generate revenue. But it's been frustrating watching the cleaning industry being cut back in terms of time, resources, and expenditures, especially on the housekeeping side. So that's really been my team's focus and the focus of our organization, that we're changing our behaviors in our process. And so I represent Sodexo. We've partnered with Lighthouse Healthcare Partners, who will be up here and talk about who they are shortly, but really to change the paradigm of how we clean and what we do. So the branding that we call, and this is a global brand, so we've moved from, or we're kind of moving now from environmental infection or environmental services to what we call Protecta, environmental infection control. To me, it's environmental infection prevention. The control was the European marketing spin to it. But it's really around managing risk. Everything that we're building is trying to reduce risk. And a lot of things that we have to look at in life, you have to use common sense. Not everything can be peer-reviewed. We would like it to be, but if we took those same principles of peer-reviewed and applied it to parachute usage, we would not use parachutes today because it's never been subjected to a peer-reviewed outcome. Because who would do the placebo, right? So there is a fair amount of common sense, and maybe it's from my background of starting from the ground and trying to work my way up and understanding the different break points and failure points that we're contributing. But it really is about reducing risk, and it's not about reducing risk in one area. It's really about reducing risk in the environment. So with that, looks can be deceiving. We talked a lot about this in the industry that I grew up in, and the industry as it is today really is visually cleaning. We look at staffing, how we staff a cleaning operation is a visual-based cleaning operation. But the reality is what we don't see is what's highly damaging and threatening to our way of life. And we have to break that paradigm, and that's where we're really going to with our new offer. I've just finished a tour of 20 cities in the U.S., a 2-day certification, training 1,000 managers. I'm now off to India next week. I've been in Europe doing this, heading to South America. This is really a journey. We're trying to break this paradigm and change the behavior. But it is a challenge because the first thing we look at is cost. And, sometimes innovations cost more. Technology advancements cost more. So, I fly about 160 times a year throughout the globe, and I really appreciate the statistic that you have a 1 in 11 million chance of getting in a plane crash. If that plane goes down in the ocean, we will spend 6 months picking every piece of that plane off that ocean floor, bringing it to a warehouse, and trying to assemble it together. And one of our earlier presenters talked about the airline industry and the rapid enhancement of safety. And this is one of the reasons. We take it very serious when a plane goes down, and we do everything we can do to fix that situation. Yet our odds in a hospital of getting an infection are 1 in 25. Why aren't we doing that same process for that individual patient? You get a plane going down every single day in our hospitals, over 200 deaths. And if you talk to a lot of the professionals in the industry, they believe that number may be a lot higher. How many people have children in this room? How many people have parents? Now, the parents is a trick question, okay? But the example that I want to use is the only number that's acceptable in this journey that we're on is 0. If it's your child, your parent, what would you be willing to do? What would you be willing to pay? Do you care that you're using an 8-cent disinfectant, or do you want the one that's 10 cents? We have to look at it differently. We have to approach it differently if we're going to get meaningful outcomes. I've been to a lot of hospitals, and they say, well, we're at our average level for our hospital system for C. diff. And I said, well, that's okay. That's a great accomplishment. I'm glad you're at the national average. How many incidents did you have in your hospital? And the answer was, well, 60 or 80. We have to break this cycle of that average is acceptable, because the only number that's acceptable is 0. So one of my roles is to go around. My team looks at different evaluates different innovations. And it's a journey we've just started. Sodexo's starting to invest a lot more money in this space. And it's something we work with a lot of individuals such as yourself. Dr. Boyce and I, I appreciate his counsel. We have breakfast. We talk about a lot of great things. And it's really learning this journey on how to affect change and finding out what is the science telling us, what are the outcomes can we drive, and how do we employ common sense in our methods. And common sense is something a lot of times that's left out that we have to look at when we look at these innovations. Otherwise, again, the parachute wouldn't be used. It's the people, process, and technology, and I spent a lot of time on this, but Sodexo and Lighthouse has really looked at what is the absolute best in class to bring forward. So we go through the research, we go through the development, we analyze it the best we can, and then we put it in place. Do we have peer reviews on everything we do? No. But the reality is we can effect dramatic changes when we do a bundled approach. And that's really what we're after. It's surface disinfection, it's hand hygiene, it's air, it's water, and it's waste. You got to attack that whole bundle simultaneously if you really want meaningful results. Because the pathogens aren't stuck on one surface, on one spot. They're continuously moving. They're getting caught in the air currents. They're on the floors. They're on the different surfaces. They're constantly moving around. And the cleaners. It's a special part in my heart because I started as a cleaner. I wanted to grow up to be a custodian. What can I say? My father was one. That was my journey in life. And I've been fortunate enough to climb up the organization, get some education, and really focus on how do we improve housekeepers' performance. Right now, we give housekeepers what I call mops and rags. You go down and they're pulling these mops out of the buckets, and you could probably see through them when you hold them to the light. They're kind of brown. They don't look very well. We're giving them disinfectants that don't work. We're giving them not enough time to clean. We have to get back to the basics of what we know works. Now, in the clinical space, we use single-use wipes, single-use microfiber wipes, pre-saturated. So why have we evaluated and determined that that is the best in class for the clinical space, yet not for the housekeeping? If you empower your housekeepers, they'll be the most loyal, dedicated team that you've ever had. And they will give you everything that they have, because most of them are doing it because they truly believe in it. But we have to invest in them. It's not about money with them. A lot of times it's just giving me the right products and the right processes to be successful. So where we've put this bundle in place, this is an example of a 6-hospital system, and we've replicated this multiple times. Did we do this in a peer review? No. But we just simply put practices in place where they were experiencing, anywhere from 8 to 10 C. diff infections a month, every single month. And we put a bundle of solutions in place. Single-use, pre-saturated, accelerated hydrogen peroxide wipe. We put in a single-use mops and wipes. We put in NADCC, a lot of different brands, Brutab, Defender, different sporicides that actually are functional. And we did hand hygiene competency training tools. And that really drove the results. And I've never seen these results in my lifetime, but we've replicated them multiple times. So appreciate your time and look forward to talking to you during the reception and during the other segments. Thank you.
John, next up we have Cliff Yonke from Indigo Clean.
Hey, very good. Thanks, everyone. Thanks for your time today. So the first thing I learned in public speaking is the 3 Bs: be brief, be good, be gone. And in about 4 minutes and 45 seconds, I'll accomplish at least one of the 3. Right? So anyway, thanks again, everyone. So what I'm going to tell you about a little bit here, and we heard this in all our other discussions, was the importance of the environment in the role of healthcare-acquired infections. And to be sure, we'd all love to provide a cleaner, safer environment for our patients, but we know that that takes typically people, which brings with it cost and compliance issues, right? So, taking all of that into account, we're trying to find ways to continually do things better, cheaper, and faster. So with that in mind, we developed this intersectional intervention called Indigo Clean. It's an overhead light fixture that kills bacteria. So the first thing is it does not use UV. It's not ultraviolet, it's visible light. You know it's visible because you can see it. The key is it provides continuous environmental disinfection without any additional labor, maintenance, or compliance. And so this is in use today in clinics throughout North America here, multiple customers. We're going to talk to you about that at the end. But the key is that this is an LED light. Sits in the ceiling, and your facilities guys love it. It lasts for 10 years. No bulb replacements, no maintenance. It's just there. Ask them how they use the lights today. And it's just like your office lights. It comes on and off with people in the room. So it's going to give you this disinfectant mode. On the left, this is white disinfection mode. So it's overhead white light for your procedures with additional antimicrobial light to kill bacteria throughout the day. And on the right-hand side, when no one's there, it shifts into high power mode. So it's still safe, it's just all blue. So now, of course, the nurses love it because they can come by and give us all their disco moves, but it's absolutely safe again. Gives you a higher level of disinfection. So again, just for the physics wonks, this works at 405 nanometer. So that's short of the ultraviolet, and over on the left is the UVC, and of course there's UVB and UVA. Those are all great products optimized for specific applications. And so how does it work? Well, very simply, this light has a lower level of germicidal activity than UVC, but that's what makes it safe. But also it operates 24/7. So over a given cycle, it can take as much bacteria out of the room. And of course, the way it works is within the bacteria is something called a porphyrin molecule, absorbs the visible light, and fragments into something called reactive oxygen. And you know what that is because you know what bleach is, right? Same effect. And I think, earlier Rush mentioned HINS, H-I-N-S. That's the academic name for the technology, high intensity narrow spectrum, where I'm one of the inventors of the product and we're the only ones licensed to use this throughout the world. So just to kind of put the two names together if you'd like. And of course, there's your epidemiological triangle, and we have lots of lab data and peer-reviewed stuff that we can share with you until you need some light bedtime reading. So very quickly, a day in the life of a room, what we recommend is that you use Indigo Clean in addition to everything you already do. So think of it like this. You start with a room after you just did a procedure or a patient, right? There's a high level of bacteria, arbitrary amount. You come in, you turn on this light, it's killing some bacteria. Then you come in and you apply your episodic disinfection. So that drops the bacteria levels down very familiarly to what you normally do. Then the bacteria starts to regrow. The key point is with a continuous environmental disinfection in place, when you come in the next day or the next case, there's less bacteria there because you've been disinfecting the whole time. And so this, of course, repeats itself throughout multiple days, and you can see you eventually build up this asymptotic limit where eventually you take about 85% or so out of bacteria out of the room, in addition to what you're already doing. So whatever you're doing, this makes it 70+%, in this case here, 85% better. So of course you can use this in the operating room. You can use it in patient bathrooms. We know C. diff is a gastrointestinal, starts there, migrates out. Folks love it for the emergency department, because they can't shut the rooms down. These rooms are chaos, as we've heard, right? They're in use 24/7. So you want something that can operate continuously and provide a cleaner, safer environment for your patients. And of course, we're out there doing all of our studies as well. We're very fortunate. Dr. Bill Rutal has been involved. I have to share a quick story here in my remaining 60 seconds. One of them, he had a sheet of 4 mic in his office with little green circles on it, and he asked me to come into his office and make some measurements of the amount of light in there. And he said, make sure you're careful. I said, why? He said, well, that's MRSA, that's C. diff, that's VRE. So being a physicist, this is a little different for me, right? I said, the thought had occurred to me. But in any case, lots of information and literature. Share on our website. It's you have a copy of our brochure in your bag. Yep, so case studies are in there, and of course, I'm available. If you can't get me after the show here, talk to Chris. We'll find a way to connect. And so with that, not only do we have actual clinical data, but we have live commercial installments. This is actually from Henderson Hospital in Las Vegas, Nevada, brand new state-of-the-art facility. They went whole hog, did all the operating rooms, procedure rooms, trauma triage rooms, their ED, the exam bays, and most importantly, when we dedicated the facility, I had to go out there and meet the president of the Pro Football Hall of Fame. The guy's 6'9" and played power forward for UCLA. The guy is huge. Yeah, so lots of fun stuff. Anyway, with that, I yield the remaining 3 seconds to the honorable senator from wherever.
Thank you. Okay, next we have Val Ramanan from Solaris.
Okay, there's a video, so we'll start with a video first. The nice and fluffy stuff that I wanted to start it off with. Like I said earlier, it seems like the panel before may have seen my slide because they've covered everything that I wanted to cover. Not only that, just listen to John LaRochelle. It looks like he stole my life. I grew up wanting to be a custodian. My dad was a custodian, so I don't know about this John LaRochelle guy. I got to send somebody to look him up. Look, panel prior to this talked a lot about technology is a need to have, not a nice to have. They've convinced you of that. We're one of those options. There are many options out there. We're one of those options. Every system, every process have its advantages and disadvantages. What we did was we went to the market and listened to the market and said, this is a need to have. Why don't you have it? And there was 2 common denominators. One was the time of efficiency and 2, cost. So in developing our system, we focused on those 2 areas. We made a system that could go into a room for about 3 minutes and priced it very fair. Our system is a xenon pulse UV technology. We're the second company in the world with this technology. I can't use the name of the other company or they'll sue me, so I will pass that. We use a broadband spectrum light, and we have 2 ways of disinfection, standard UVC and the photon bombardment of the high-intensity pulse UV light. This is a light bot. Like I said earlier, it runs a 3 to 5 minute cycle. It's positioned twice in a room. We use a technology that's called max pulse technology. The light is pulsating at a very, very high frequency, and that's what's letting us get the efficiencies that we're getting. What we've also done was we optimized our reflector system in the UV lamps. What we have is we focus a lot on high-touch areas. Our light's not going to the ceiling. We don't need to go to the ceiling. We're focusing on bed handrails, doorknobs, and things like that. Here are some of the results that we've gotten so far. These were done in third-party labs. You can see that there, but I'm going to zoom through some of this stuff because I want to get to the floor coatings because I've got 1.5 minutes left, and I want to touch on this because this is something we thought about for years. For the last 10 years, I've been preaching this, and no one believed me. Today, we heard what people are saying. What we've got is a UV curable floor coating. So basically, the floor coating goes down to the floor. It cannot be cured unless there's a UV light on it. It's like going to the nails for the guys and girls that get their nails done. Basically, we put down that floor coating, we zap it with a light, it's cured instantly. But it's equivalent to about 20 to 30 coats of wax. It's 100% solid content, and it has nano silver technology in there. Studies that we've done so far has shown that this continuously works as an antimicrobial agent. And with that, I will close. My time is up.
Thank you. Okay, next we have Rick Heller from Wello.
Hello, my name is Rick Heller. My background is electrical engineering, and my dad was in retail. When you see our device here operating, and you'll see it all day tomorrow, think of non-patients, think of an oral thermometer, and think of self-service. If you put all that together, what we're actually fighting to do here is to stop the shedding of what could turn into HAIs by febrile or fevered people. And this all came about as a result of my interest in epidemiology and math and studying SARS. And in the case of SARS, here's the community, here's the hospital-acquired infection, and you've seen the studies that look at the 7-Eleven nearby or the laundromat nearby a hospital, and they share similar biome. So you know that when hospitals clean and they go after their HAIs, other hospitals in the area without necessarily initiative benefit. So what we have here is what we think part of the problem is. So there you are. The barn door is open and disinfecting, and all these things we're talking about come after the animals have gotten out. We have to get them back in. So we look at one of my most interesting subjects, which is SARS. And what you see here is 200-300 people who got sick in Singapore. And you see the circles around those are 5 people, and they call them super spreaders. It's just a definition that comes out after you look back on it. And those super spreaders, would they not have been there, nobody would have gotten sick. And what we find out about super spreaders, and at the time, it was very important to figure out, who has these immune systems that just, blow this virus everywhere. What is special about these people? Well, as it turns out, what's special about these people is that they got out. They went about, they went to a hotel. One of the circles there was intubated, and the device was actually just pouring his respiratory system into the air. That led to about 50 infections in Hong Kong. So what they did in SARS is they actually took temperatures twice a day of all non-patients in the hospital. And from that, they found, and by the way, they did this at the border in Singapore, and they did this in schools, all schools. And what they found is 1 in 4 of the fevered people in the hospital had SARS. So that's kind of a bounty, a big deal. But then the question comes up, why are 3 out of 4 people, why are the other 3 people in the hospital at all? This was something that affected healthcare workers profoundly. So we did a study, actually this is data mining, and what we found out, and I'm sorry if it's not illustrative enough, but we found that 110 out of 117 at a clinic that was for people with disease, infectious disease, came in there. And what we found is that at 100.4 and above, 7 of them were febrile. And we took the 99.1, which is a pretty strong, pretty low level for calling it a fever, but a subacute fever nonetheless. And the reason we did that is because right next door was a rehab center. And in a rehab center, you don't come in there sick. You're going to be doing rehabilitation. And they had no incidence of this. And this is about a 700-person study. So we think that we are being cavalier in that. And you've heard probably that the day before your infection or your fever and the day after you're infectious. And where that is true so far as testing positive for influenza, this, the CDC, NIH, and some others report, actually show quite a different story. And what you see is that the body temperature and the symptoms and the amount of time and the viral titers that come out are all very much in sync. So no fever, no contagiousness. With contagiousness comes fever. So we're not saying you're well, we're saying you're Wello, that means you're not contagious. We know about fever. This is a very interesting slide with 10 seconds to go. And so who the heck is working sick? And this is a slow slide, and I'm done. Anyway, the whole point of this is that we believe that the bioburden and contagion burden is coming from febrile people to some extent. And I thank you very much for your time.
Can I ask you a quick question? So I didn't understand. So is your device then detect people who come in a room or in a facility or area that have a fever, and then alerts you that they have a fever?
Correct. Right now it's in the front of bone marrow transplant. It's when you come into a bone marrow transplant, obviously you know how serious that is, and so they'll reject you if you have a fever. And so it's not anymore a survey question, have you had a fever over 100 degrees in the past 24 hours? Now it's just a matter of, scan in. And we have, in one bone marrow transplant place, we have gotten 3 out of 20,000 scans of people who are febrile.